If you've been watching videos about dry mouth recently, you probably already know it's not a minor thing. You know that your saliva is doing more work than most people realize, and that waking up with a bone dry mouth every morning is your body trying to tell you something important. That part is true. The videos that say that are right. But here's what almost none of them explain. Your doctor probably told you to get your blood sugar checked. Maybe you did. Maybe your A1C came back normal, or close to normal, and you felt reassured. Except your mouth is still dry every morning. And the question nobody answered is, why? I'm Dr. Daniel Haar. I've spent 21 years treating metabolic dysfunction, specifically insulin resistance, before it ever becomes diabetes. And I can tell you with confidence that blood sugar is a late stage measurement. By the time your A1C is elevated, the real driver has been chronically elevated for years. Before this video is over, you're going to know exactly what to ask your doctor to measure, something most physicians never order on their own, and why that single number explains what your A1C has been missing. Let me be specific about what I mean, because this distinction matters enormously. When most videos about dry mouth mention blood sugar, they're pointing at a symptom. High glucose in the blood pulls water from your tissues, including your salivary glands, and that contributes to dryness. That mechanism is real, but here is what those videos skip entirely. The salivary glands are not damaged by glucose alone. They are damaged by insulin. Chronically elevated insulin, the kind that precedes elevated glucose by a decade or more, triggers a completely separate chain of events inside the glandular tissue itself. And by the time your blood sugar shows up on a test, that chain of events has already been running for years. This is not a minor finding. A 2025 meta-analysis published in BMC Oral Health, covering 23 studies and over 2,400 patients, found that roughly 42% of people with type 2 diabetes experience chronic dry mouth. That's nearly half. But the research also found no significant difference in dry mouth prevalence based on how long someone had been diabetic, which tells you something critical. This starts early, not at diagnosis, before diagnosis. And most people have no idea that the problem began years before anyone told them they had a blood sugar issue. So let's talk about the actual mechanism, because once you understand this, the morning dry mouth stops being a mystery. Your salivary glands, all three major pairs of them, are extraordinarily sensitive to blood flow. They require a constant, precise microvascular supply to produce saliva, and they are regulated by the autonomic nervous system, the same system that controls your heart rate, your digestion, and your ability to respond to stress. When insulin remains chronically elevated, two things happen in parallel. First, the microvascular supply to the salivary glands is compromised. Chronically elevated insulin reduces the bioavailability of nitric oxide, the molecule that keeps blood vessels dilated and blood flowing smoothly. When nitric oxide drops, the tiny capillaries feeding the salivary glands constrict. Less blood flow means less raw material for saliva production. A 2025 study published in Medicina Oral examining the carotid glands of diabetic patients using ultrasound imaging found statistically significant reductions in microvascularity compared to healthy controls, with a direct negative correlation between the duration of metabolic dysfunction and blood flow to the gland. The gland is being starved of circulation. Second, and this is the mechanism most endocrinologists are not explaining in the 15-minute appointment, chronically elevated insulin triggers the accumulation of advanced glycation end products, what we call AGEs, inside the glandular tissue. A 2025 review in Glycoconjugate Journal documented this pathway in detail. AGEs activate a receptor called RAGE inside the salivary gland cells, triggering oxidative stress and structural damage to the acinar cells, the cells actually responsible for producing saliva. And critically, AGEs also damage the autonomic nerve fibers that tell the gland to secrete. The gland loses its blood supply, then it loses its nerve signal, then it stops producing saliva at normal rates. And this is happening before your A1C is elevated. Research published in the Archives of Oral Biology confirmed that insulin resistance, defined specifically by hyperinsulinemia with normal or near normal glucose, already produces impaired insulin receptor signaling inside the salivary gland tissue. The gland develops its own form of insulin resistance, and when the gland becomes insulin resistant, the secretory mechanism breaks down. That's the part that most videos on dry mouth completely skip over. I know what some of you are thinking right now, especially if you've seen other videos about what dry mouth means. You're thinking, but my A1C was normal. My doctor said my blood sugar is fine. How can insulin be the problem if my glucose is okay? Let me explain exactly why that question has a different answer than you've been given. Glucose and insulin are not the same measurement. Your body can maintain a normal fasting glucose, even a normal A1C, while your fasting insulin is 2, 3, or 4 times higher than it should be. That excess insulin, the body's attempt to compensate for cellular resistance, is the chronically elevated driver I'm describing. The glucose looks fine precisely because the insulin is working overtime to keep it there. Your doctor checks blood sugar. That is a measurement of outcome. Fasting insulin is a measurement of mechanism. And in endocrinology, when you're treating metabolic dysfunction before it becomes diabetes, fasting insulin and the HOMA-IR index, which calculates insulin resistance from fasting glucose and fasting insulin together, are the numbers that actually tell you what is happening inside your tissues. In 21 years of practice, I have seen patients with perfect A1C readings whose fasting insulin was chronically elevated and whose salivary glands, cardiovascular system, and cognitive function were already showing the downstream effects. The glucose number was reassuring. The mechanism was not. Let's go one level deeper, because the oxidative stress piece deserves its own section. A 2019 study published in Oxidative Medicine and Cellular Longevity, using animal models with diet-induced insulin resistance, demonstrated that the salivary glands developed measurable mitochondrial dysfunction before any significant systemic oxidative stress was detectable in the bloodstream. The parotid glands, specifically, showed impaired mitochondrial respiratory chain function, meaning the cells that produce saliva were losing their energy supply at the cellular level. What this tells us is that the salivary gland damage from insulin resistance is not a downstream consequence of general metabolic deterioration. It is a local, organ-specific event. The gland is damaged earlier and more specifically than the rest of the body signals trouble. This is why the morning dry mouth is such a valuable signal. You're not experiencing it because you're dehydrated. You're not experiencing it simply because you're aging. You're experiencing it because your salivary glands are showing you, in real time, a local manifestation of what chronically elevated insulin is doing to tissue throughout your body. The gland is the canary, and it's telling you something the blood sugar test is missing. A lot of videos on dry mouth will tell you to check your blood sugar, get your A1C, look at your medications, and that is all reasonable, useful advice. That's true. But what those videos don't explain is that insulin resistance is damaging your salivary glands through microvascular and autonomic pathways that are invisible to standard glucose testing. And that distinction matters enormously because it determines whether you're addressing the symptom or the mechanism. In just a moment, I'm going to show you exactly what to ask your doctor to measure and what the research suggests you can actually do to begin reversing this process. Here's what I see consistently in metabolic medicine. Let me walk you through an illustrative scenario. Let's call her Patricia, 64, a retired high school teacher from Phoenix. Patricia had been waking up with a bone-dry mouth for about 3 years. She'd mentioned it twice at annual checkups and been told it was probably a side effect of her blood pressure medication, or just aging. Her A1C was 5.6, which her doctor described as borderline but not concerning. So she bought a humidifier, started keeping water by the bed, and got on with her life. When she came to see me, I ordered a fasting insulin alongside her standard fasting glucose. Her glucose was 94, completely normal. Her fasting insulin was 19. Her HOMA-IR was 4.4, well above the threshold where we start seeing downstream tissue damage. Patricia didn't have diabetes. She had chronically elevated insulin, and her salivary glands had been telling her that for 3 years. nobody had ordered the test that would have explained it. This is not an unusual case. It is, in my experience, a very common one. Here's how I would actually approach this if I were sitting across from you in the exam room. First, ask for a fasting insulin test alongside your next fasting glucose. They are often run from the same blood draw. The difference is just the order your doctor places. Ask specifically, can we check my fasting insulin and calculate my HOMA-IR? If your HOMA-IR is above 2.0, and especially above 2.5, that is a signal worth taking seriously, regardless of what your A1C shows. Second, understand that the salivary gland damage from insulin resistance responds to the same interventions that reduce insulin resistance systemically. The research consistently suggests that time-restricted eating, meaning compressing your eating window to 8 to 10 hours, reduces fasting insulin significantly in adults with metabolic dysfunction, and does so within weeks, not months. A walking routine, specifically 20 to 30 minutes after your largest meal, has been shown to blunt the postprandial insulin spike that is one of the main drivers of chronic hyperinsulinemia. These are not complicated interventions. They cost nothing, and the mechanism is elegant when you think about it. Less insulin stimulation means less oxidative stress in the glandular tissue, which means the cells producing your saliva have a chance to function the way they were designed to. Third, protect your oral environment while you address the underlying mechanism. Use an alcohol-free dry mouth rinse at night. A cool mist humidifier in the bedroom reduces the evaporative loss that makes morning dryness worse. And stay consistent with dental visits, because as the research shows, the microbiome shift that comes with reduced salivary flow has real downstream implications for your cardiovascular and cognitive health. The dry mouth is the signal. The insulin is the mechanism. And the mechanism, research suggests, is modifiable. Here's the summary I want you to leave with. Your doctor checking your blood sugar is not wrong. It's just incomplete. By the time glucose rises, the mechanism driving salivary gland dysfunction, cardiovascular stress, and metabolic decline, which is chronically elevated insulin, has been active for years. The morning dry mouth is not a random inconvenience. It is a local, organ-specific signal of what insulin resistance does to tissue with a high microvascular demand. And the number your doctor is not measuring, fasting insulin and HOA-IR, is the number that explains why your A1C is normal and your mouth is still dry. In 21 years of treating metabolic dysfunction, the patients who change trajectory are the ones who ask better questions. You now have the mechanism. You have the questions. Use them. And if this explains something your doctor hasn't had time to cover, send it to someone who needs to hear it, because this information changes the conversation. If you want to understand how chronically elevated insulin is affecting your cardiovascular system through the same microvascular pathway we discussed today, that video is next. The mechanism is the same. The organ is different, and the implications are just as significant.